Welcome everybody, and thank you for attending the second session of the simulation week. Today we have Ms. Ohud. We are lucky to have her. She has a master in advanced nursing education, supervisor of Interprofessional Education unit, and nursing research officer, with more than 6 years of experience in nursing education and clinical simulation. Also, she is a national speaker for clinical teaching and training. أهلا وسهلا.
أهلا بكم جميعا.
أعطيك المايك أستاذة أهود.
Yes, I'm super excited to start.
حتى إحنا والله. تفضلي.
Welcome all. It's a pleasure to have you all with us tonight, and welcome to Healthcare Simulation Week 2021. I'm very glad to be with you on this lecture, and tonight I'd like to introduce all of you to interprofessional education, and not only interprofessional education, it's intra-professional education too. Let's start with our outlines. Okay, before the outlines, usually when I'm doing this kind of lectures, I prefer to do it physically to see you all, but unfortunately we couldn't do that. You just know me, but inshallah in the future I can know every one of you. Let's go to the outlines for the one lecture talk or the 1 hour talk for tonight. Our lecture will be divided into 3 sessions. First session is what is it all about? Session 2, what I'm doing in a multidisciplinary team. Session 3, IP through simulation-based education. Then we will have our closing remarks. Learning objectives, which I'm, inshallah, planning to provide to you is at the end of this lecture, participants will be able to define the IP as a pedagogical approach, understand the importance of the 4 core IP competencies, identify the role of simulation in the IPE approach. Our first session called What is it all about? When I'm talking about the IPE, it's the abbreviation of Interprofessional Education. What does IPE stand for? Briefly, the IPE is occasion when students, participants from 2 or more professions in health and social care learn together during all or part of their professional training with the object of cultivating collaborative practice for providing patient-centered care. Mainly, we are gathering students, participants from different healthcare professions to provide training or education to them to achieve the collaborative practice in the real clinical settings. Okay, so what about simulation interprofessional education? Simulation interprofessional education is the overlap of the pedagogy of simulation and interprofessional education, which enables participants from different professions to engage in a simulation-based experience to achieve shared or linked objectives and outcomes. And it's well known that most of the healthcare providers and most of healthcare professions having shared and linked objectives and outcomes because we are serving and taking care of the same patient at the end of the day. Why interprofessional education, or from where we get the idea of interprofessional education? The WHO, or the World Health Organization, created a framework for action on IP and collaborative practice. The WHO says we need first to assess the needs, the local health needs, then develop interprofessional education in the undergraduates. In our formal education, the education institution should start the interprofessional education and teach students or student healthcare colleges, together. Then we will reach the collaborative practice in the real clinical settings that will lead to improve the health outcomes. Why interprofessional collaborative practice? Okay, we can ask ourselves, if we start the interprofessional education in our formal training or in the universities or in the education institution, why we need to get the collaborative practice in the real clinical settings? First, empowers team member. Our team members will be empowered. It closes communication gaps among the different professions, like the medicine, the nurses, the pharmacists. Maybe the medicine and nurses usually working together and they know each other, but what about the other professions? The pharmacists, the PT, the RT. So this kind of education them or training them together will close the communication gaps among them in the real clinical settings, enable comprehensive patient care. We are caring the same patient, so we need to provide a comprehensive patient care. Minimize readmission rates. The evidence base says education or interprofessional education and collaborative practice have a positive impact on minimizing the readmission rates. Promote team mentality, promote patient-centered care, and to prevent medication errors. Based on the evidence base, this says IPE or interprofessional education and collaborative practice could prevent the medication errors which comes from the miscommunication. Factors that influence interprofessional collaborative practice. So why we cannot start or we cannot create, we cannot develop the interprofessional education to reach the interprofessional collaborative practice. First, scheduling. We have each faculty, each college, each university has different schedule, the rigid curriculum. We have started in the Princess Noura University or the Simulation Center in the Princess Noura University, the idea of integrate IPE curriculum into the healthcare colleges and faculties and the PNU. It was very difficult. It's not impossible, but still we are trying to integrate our curriculum, the IPE curriculum, in their curriculum because they have a rigid curriculum. So it's not easy to add educational material to the university or the faculty curriculum. Lack of a perceived value of the IPE. The IPE, we don't have that awareness or the high awareness of the importance and the value of interprofessional education. So that's why we didn't start yet to integrate it in the curriculum. Logistical and resources issues, geographical location and physical space to gather students and participants from different healthcare colleges and faculties need a space. So sometimes the university cannot provide that space. Faculty time, and I see this, the faculty time and the rigid curriculum, the most factors that affecting the interprofessional collaborative practice. The faculty time, we know that the faculty has a full schedule, overwhelmed most of the time. That's why they are not providing the IPE part of or time on their curriculum or schedule. How we can overcome, or before overcoming the barriers, we need to see the barriers of not implementing and creating and starting the interprofessional education to reach the interprofessional collaborative practice. First, organizational barriers. Sometimes the hospitals and the institution or the policies not supporting the interprofessional collaborative practice. Barriers at the team level. The physician wants to work alone, the nurses want to work alone, the pharmacist wants to work alone, and they keep fighting in the real clinical settings and keep the conflict keep raising among the team because there is a barrier at the team levels. In the nursing or in the medicine, in the pharmacy, they keep teaching us that we are the most important team. We are the most important person. That patient is mine. We are not sharing that patient. I'm the one responsible for that patient. No one is responsible for it. We don't have that of awareness of taking care or share responsibility among the different healthcare professionals. Barrier faced by individual team members, sometimes it's characteristics, it's personal characteristics that affect the interprofessional collaborative practice. How to overcome these barriers? First, start IPA curriculum. I will keep trying and keep digging into implement or at least have it in the curriculum. It's not supposed to be in the formal curriculum. It could be a hidden curriculum, or find the way to add it in the curriculum. Shared mental model. All the healthcare faculties need to have the shared mental model and teach the students that we are taking care of the same patient and we are having the same objectives at the end of the day. Okay, that was the end of session one. Session one was talking about, it was quite heavy of having definitions of interprofessional education or the simulation interprofessional, the barriers that affect the interprofessional collaborative practice, and how are we going to overcome all of these barriers. For the session two, called What I'm Doing in a Multidisciplinary Team. In this session, we will discuss the IPE Card Competencies. The IPE Card Competencies guide interprofessional education and practice initiatives. For these competencies, all of us, we know these competencies, but we don't know that these are the IPE Card Competencies. I know some of them or some of these competencies already added in the curriculum, and already the faculty teach students regarding this, but they are not having the full concept of these competencies as IPE core competencies. The first step needed to implement the core competencies is to ensure that the faculty, educators, students, practitioners are all aware of these competencies. Let's just start with our first core competency: value ethics for interprofessional practice. Work with individuals of other professions to maintain a climate of mutual respect and shared value. We are expecting that we are having the same value and ethics, but we are not sure. Not sure. In the real clinical environment, I never trained with another profession. I never had or formal education with another profession. How can I know that we are having the same value and ethics? We're expecting that to have the same value and ethics, but we never know. And for the simulation, from my experience, I never seen a simulation scenario regarding value and ethics and teach students how to treat patients ethically and having the same value when we are treating that patient. So we need to increase that competency in the simulation scenarios and teach our students how they are going to have a well-structured value and ethics toward their patients, not only toward their patients, they need to have it toward their colleagues. They are working together, they need to have the mutual respect and shared values toward each other and toward their patient. For the second core competency is role and responsibility of other healthcare professionals. Yes, I think this is a very, very, very important competency. Understand the role and responsibilities of the different healthcare professionals on the team in providing safe, efficient, effective patient-centered healthcare that optimize outcome. I know the other professionals by having a friend in that profession or hearing about that profession, but we never know the real role of each profession. I was when I was working in the pediatric ward, once one of the team members went to my patient room and I was staring at her. I don't know her. And I keep staring at her and I just followed her to see what she's doing to my patient, because I'm being told that this patient is mine. This patient is mine. I'm having the full responsibility for that patient. I'm not sharing that responsibility with anyone or with any healthcare provider. Then I went the room inside and she was talking to that patient. I keep staring at her and I didn't introduce myself. She didn't introduce herself. I didn't ask who you are. And she went out. I followed her again and I just waiting for the notes to see who is she, but we didn't talk. And when yes, when she was in the room, she was doing exercise to my patient, and then when I realized she's the PT, when she went out, okay, is the PT doing this? Okay, this is my first time seeing the PT taking the full history of that patient and doing the full exercise to that patient. And she wrote the very interesting notes. Oh, is that, the PT is doing this, doing all of these tasks. So I never know that the PT is doing all of this. So we don't know the real role and responsibility of other healthcare professionals. And the simulation, again, we can, if we have the interprofessional education and combine it with the simulation scenarios, we can have the great scenarios for role and responsibility. We have the shared objectives, we are taking care of the same patient, even we can provide that care together. So in the simulation, I strongly encourage the simulation centers or the simulation educators to increase the scenarios or develop scenarios regarding role and responsibility. I'll share a story with you later regarding the role and responsibility, and you will find that how this is important to have a clear idea about others' role and responsibility. Interprofessional communication. This is, I think this is, yes, we keep teaching students about the communication, communication with patient families, communities, and other health professionals in a responsive and responsible manner, listening actively and seeking common understanding that supports a team approach to the maintenance of health and the treatment of disease. For the communication, we keep teaching students regarding communication, and this is have the largest portion of the simulation scenarios, and we thought IPE is only communication, not. IPE has 4 core competencies. We need to keep teaching students regarding each one of these core competencies, not only communication. Team and teamwork. Apply relationship building values and principles. This is the 4th core competency. Principles of team dynamics to perform effectively in different team roles to plan and deliver patient population-centered care that is safe, timely, efficient, and effective and equitable. Team and teamwork, we need to teach our students how they become a team player, how they engage in a team, or how to participate in them, not only in their team as physician or the pharmacist or as a nurse. No, we need to engage them how to be a team player in a multidisciplinary team, and how the team works is supposed to be. So even we don't have many scenarios, or we have a rare scenarios talking about the team and teamwork among the multidisciplinary team, and this is a very good opportunity to start building our scenarios in the simulation regarding team and teamwork in a multidisciplinary team. Okay, so we have discussed the 4 core competencies for the IP or interprofessional education. It's not only applicable for interprofessional education, it could be applicable for intra-professional education. I'd like to share a story with you regarding the interprofessional education. In the last summer school, or research summer school, which was conducted in the research center and Princess Noor University, or at Princess Noor Ibn Abdulrahman University, we participated. I was one of the mentors for one of the team. They were dental team, dental students. I was one of the mentors to mentor them in their research. I was one of the mentors. The second mentor was dentist, and we ended up with a research called Intra-Professional Relationship among the dental team, qualitative study, and that research won the first place in the best poster presentation. the research was talking about the interprofessional relationship among the dental team. The dental team consists of a dentist, lab technician, hygienist, and dental assistant. And we conducted three focus groups and a total of 12 participants. In each focus group, we had one pharmacist, one lab technician, one hygienist, and one dental assistant. We keep them talking. We conducted focus groups, so it was a kind of interview or a group discussion, sorry. So we keep them talking about the interprofessional relationship among the team. We're surprised with the result. Among the dental team itself, they don't know their role and responsibility. The dentist surprised with the hygienist's role and responsibility, surprised with the hygienist's tasks and what she or he being taught in the university. She said, one of the participant or the dentist says, oh, I keep doing that tasks because I thought you don't know how to do it, or your teaching and education didn't teach you or didn't educate you about these skills. The hygienist said, no, I had a formal education regarding these skills. I'm well known to, and I can do it perfectly, but I thought that you are stealing my task. And they keep chatting regarding this, how the hygienist and dentist, they don't know the real role and responsibility for each one of them. Even the communication and the relationship among the team, they have a very weak and poor communication. They don't communicate. They are one team. They don't communicate with each other. Even the dental assistant with the dentist, the hygienist with the dental assistant, we found that the interprofessional relationship among the dental team itself is not very well established, because they recommended at the end of the focus group or the discussion, they recommended that we need to study together, we need to have our education together, we need to know each other, to not surprise with each other in the real clinical settings. And one of the recommendation was the IPE, start interprofessional education among the dental team. And I can say that it's not only the dental team, it could be in the health applied science. They have different profession, and one profession has a subspecialty under that. So we can start with the intra-professional education, not only interprofessional education among the other profession. The profession itself has many specialties in it. So we can start applying our 4 core competencies. And inshallah, that research will be published soon, and inshallah in this. But from this research, I have the idea of encourage faculty and education institutions to start the intra-professional education, not only the interprofessional education. Okay, we have finished our session 2 regarding the 4 core competencies of the interprofessional education, and I personally encourage that start the interprofessional education core competencies, applying it in the simulation, neurocurriculum, as well as look at the interprofessional education. You will find in your profession area to add it as interprofessional education if it couldn't be interprofessional education. Let's go to the last session for today. It's the IP through simulation-based education. Simulation-based experience are recognized as an effective way to promote IPE teamwork. The evidence base says the simulation-based experience is one of the best ways to implement interprofessional education. Having scenarios, keep students having the same teaching or the same training in a safe learning environment will improve their skills, because in our teaching, our formal teaching, we keep focusing on the technical skills, how to insert cannula, how to insert the central line, how to insert the chest tube, how to operate the patient. All of these are very important, but as well as we need to focus on the non-technical skills, and the IPE with the simulation will provide that opportunity and that chance to the student, to our students and participants, to have data training in a safe learning environment, not only for students, it's even for the participants, which I call them the postgraduate. For the postgraduate, I think we need to gather the staff, and we can train the staff and have them having their training together as nurses, physician, pharmacists, PT, RT, and provide them with interprofessional education to reach the interprofessional collaborative practice. But they focus on the undergraduate because they want to start it from the beginning, from the undergraduate and their formal education. But it's not only limited to the undergraduate. If it's applicable to be postgraduate, yes, we can provide it to the postgraduates as well. Simulation and IPE both are linked to patient safety, yes. Both of the IP and simulation are linked and having the same objectives, the same goal to provide a safe care to our patients. So I'm encouraging all of you at the end of this lecture to start thinking about interprofessional education and interprofessional education and add it to your curriculum and education. This was a quick introduction to interprofessional and interprofessional education. I hope you enjoy it. It was very quick and very interesting to talk to all of you. Thank you so much for listening. And do you have any questions? I'm ready.
Thank you so much, Ohud. It's very, very informative lecture. IP is very important. I agree with you. I have a question. So from your opinion, how we can get rid from the challenging? It means, what is the first step to implement IPE?
The first step, I think the first step is we started the first step when we asked each faculty to please look at our curriculum and find the way where you can apply it. We created a committee called IPE committee in the simulation center, and we have a representative from each faculty, and we discussed that with each one of them, of the representative, and we asked them to please look into your curriculum and look into our curriculum where we can apply it, even if it's not a formal curriculum, but at least we will have a session in your curriculum. It's a baby steps, but at least we are trying to gradually integrate it. So the first step is look into a curriculum and find the way where you can add it.
Excellent, Ohud. Other question from Dr. Sayed. He asked you, do you have any practical example of running interpersonal simulation in PNU?
Practical example, not yet. We just started last semester. But for the PNU, yes, the healthcare faculty is usually doing something, they call it a boot camp. It's initiative from one of the faculty. They do a IPE boot camp, doing it for 2 weeks, continuous 2 weeks, and they are usually doing it in the summer, and that's all. It's not formal curriculum, but it is activity called IPE boot camp. It's very successful, and they are doing it in the simulation center.
Excellent. Thank you so much. We have also.
Can I add something regarding?
Sure.
Yes. For the interprofessional education, internationally, if you want to find out more examples, internationally they started creating and building centers for interprofessional education, not only curriculum. We are now in the curriculum level, but if we want to compare ourselves with internationally, what they are doing with IP or interprofessional education, they starting in the simulation centers, they starting doing special centers for interprofessional education and collaborative practice. You can look at it and search for it.
Excellent. Thank you so much, Ohud. We have also one question from Prof. Boker. How to book different groups in the same time?
Yes, was arranged with the faculty. In the committee or in the IPE committee, we were planning to do IPE internship, and we will inshallah conduct it soon. We communicate with the internship coordinator from each faculty to provide us with the available time, and we look at it. Alhamdulillah, we found a suitable time for the 5 faculty, and we nominate students based on their availability on that time. So if you want to have available time or having the available time, you need to have a coordinator in the faculty to just arrange the available time among. It's quite difficult to have available time for the 5 colleges, but at least, as what I have says, 2 professions more and more, it's IPE. So if you cannot get the 5 specialties, I'm talking 5 specialties because the BNU having a 5 healthcare faculties, but it could be less and it could be more. So if it's 2 and more, this is IPE. You don't need to gather them or gather all the specialty together. No, it's based on the case, based on the scenario. Sometimes that scenario needs only 3 professions, sometimes 2, sometimes 4. So based in the scenario.
Okay, thank you so much. Actually, Ohud, you open our mind in the importance of the IPE. Thank you so much.
Yes, because now we are in the awareness. I'm trying. It's not only me, as a team, we are trying to raise that awareness for interprofessional education. We cannot start to implement something that we don't have the full awareness and full picture of it.
Sure, I agree, totally agree. So this is maybe the end of our first session today. Thank you so much, Ohud. We have another question.
Yes.
If you were to do IPE in the postgraduate education, how would you organize this?
I think it's very easy. For the postgraduate, I think it's very easier. It's easier than the undergraduates, because undergraduates having a rigid curriculum, different scheduling. But for the hospital, I think, or for the postgraduate, I think they have more flexibility, that it could be educational sessions. It could be one of their training, the hospital or the department itself, or the academic affairs in that hospital or that institution could plan it for them and send the staff from different professions to it. So I think for the postgraduate, it's easier than the undergraduate.
Okay, this is the answer to the question.
Your question.
Yeah, sure. I don't know, from my side, I understand. It's answer the question. So thank you so much, Ohud.
No worries, anytime. And this is my communication. If you have any question later, or if you want to have a more about IP, I'm ready. And I'm always. Thank you so much. Have a good night. Oh, thank you.
You too. Thank you so much. Thank you. Thank you, everybody, for attending the first session. So we want to go to the second session now. Just to make sure Ghada is here.
Yes, hello, I'm here.
Hello, Ghada, how are you? Fine?
I'm fine. How are you, doctor? How are you, everyone? I am trying to share the...
Thank you so much first for participating in the simulation week. And we hope we get benefit and all the audience. Thank you so much.
Thank you so much, Dr. Rahmani, for arranging this. أشكر الجمعية على استضافتي في الأسبوع التوعوي للمحاكاة. I hope my presentation will be helpful to you. First, I will introduce myself. I am Ghada Almujli, and I will be introducing.
You want me to present you or you present yourself?
Up to you, doctor.
As you like. Okay, I will present, and if you I missed something, you can add. Okay. Ms. Ghada Almujli, she's a dietitian with a Master of Clinical Nutrition, Master of Medical Education. Currently, she is simulation educator at Prince Noura Bint Abdurrahman University, working in several projects related to simulation, acting, design, and involving in simulation activities and committees. She is also a health educator specialist certified. Did I miss anything?
Thank you, Doctor, for the generous introduction. Thank you. I will be presenting the topic, how to ensure the quality of healthcare simulation scenarios. The topic is important because to conduct the simulation session and the simulation activity in general, you have to ensure that is based on a very rigorous and robust design. So by the end of this presentation, you will be able to list the steps of designing high quality simulation scenario, identify the quality standards of simulation scenario design, and finally recognize key steps of quality assurance protocol of simulation scenarios. So a brief introduction about healthcare simulation scenario education. Following the success in different fields, the simulation activities and simulation education has become a key and a critical aspect of healthcare education. And to be successful in designing this technique in teaching and education, you have to address critical needs and to target and assess the participant needs and the performance in those activities. So if before starting on how to ensure the quality of simulation scenarios and simulation activities, we need to know the key aspects or the criteria and elements of the design to be able to design a protocol that is suitable to assess the quality indicators. The simulation design elements and criteria are very known among all of us. This is a very quick and brief summary of those elements and criteria. I'm going to shift the focus on the design, and I focus on the quality of each steps and the criteria and those elements. So the elements are the needs assessments, measurable objectives, and the format of the simulation education. Then moving on to the designing of the clinical scenario or case, to choosing the fidelity, and moving to the facilitator and facilitative approach, the briefing of participants, and then the debriefing and feedback. The evaluation is a key aspect, and the participant preparation also is what determines the success of the simulation experience. And finally, testing the design or the model. The first step, which is the need assessment, you need to explore the gap that you have in your organization, curriculum, or program to be able to design the simulation experience that caters this gap and targets to fix it and train your participant based on that. So there are several methods you can use to do the need assessment. You can do a root or cause or gap analysis. So an example for that is if you are looking at an undergraduate curriculum, you will find that some objective or outcomes can be targeted with other methods other than the simulation scenarios or simulation education. Some are previous data in healthcare. If you find critical errors or, for example, errors in the care, you can design a simulation scenario that targets this gap. Also, the standards in the healthcare field. Of course, before all that, before the design, you have to analyze the organization itself. So what we usually focus on is the strengths, weaknesses, opportunities, and threats, or the SWOT analysis. This will help you to decide how the simulation experience is of course, it targets the gap, but you will have to make sure that resources you have in your organization is capable of covering this demanding education technique. Surveys are also preferred for need assessment. You can survey the stakeholders, clinicians, or educators. After all that, you will design an overarching goal for the simulation-based experience and scenario. And then you will move on to specific learning objectives for the scenarios. We usually, when we are designing the objectives, we want them to be achieved, and there is an acronym for that. And it has to be measured using a standardizing checklist, for example, or it can be summarized in critical actions that can be implemented in the simulation scenario. So the acronym we use when we are drafting the measurable objectives are SMART, which is specific, measurable, attainable, relevant, and time-based. An example for that, if this is an example of how to draft this the measurable objectives. From my perspective, if I am looking at a simulation scenario and I am reviewing it before implementation, and if I see the title that scenario focus on communication with patient caregiver, I expect there are objectives that target how effective the participant will deal with the patient caregiver. Similarly, if I'm looking at a scenario about pediatric patient transfer, I expect there is an objective that will use SPAR during the patient's transfer. Moving on to the format of simulation-based experience, you finished all the designing of the measurable objectives and need assessment, and you drafted the purpose of this experience. Then moving on to the purpose of the simulation-based experience and scenario. Is it a formative where we would give feedback to the participants, or is it summative where the participant will be graded on this? And there is a pass and fail, for example. You will design the theoretical or conceptual framework. The purpose and the level of the participants determine this step. So I expect, if I'm reviewing a scenario, that the level of participants and the purpose is aligned with the scenario itself. It shouldn't be advanced for the participants or below their level of experience. Also, if it's the purpose, as for the previous example, which is a transfer, I don't expect communication during, unless it's part of the objectives. The modality also plays a part here. What is the platform for the experience? Which is the modality you are using? There are several modalities that is used for simulation-based experience. You can have it as a procedure simulation where you're using task trainers, virtual reality, or you combine modalities such as standardized patient and partial task trainers, or avatars and mannequins. So after finalizing those aspects, moving on to how to format it from start point to structured critical actions and steps to the end point. So if I'm having the scenario in front of me, this is an example of a scenario that we have, and I'm reviewing it in the committee, for example, and I expect there is a step 1, step 2, and there is an endpoint for the scenario. I expect step 1 to show what is the critical action that should be done, or what is the learner action in this step. And the transition should be very seamless. That is, if there is a different aspect, for example, in step 1 that is not achieved, there is a cue or a prompt that can be given. So it's like a smooth transition between those steps and seamless that I can reach the endpoint. So for this example, and this is the designer of the scenario wanted to make it as a formative assessment and training. And the modality, because it was aiming to teach infection control measures, and it was focusing on the setting itself, the designer of the scenario chose to put it as a mannequin, a high fidelity mannequin, because she wanted to add the vital signs. And the endpoint can be determined based on the writer of the scenario. They can add it as time-based or by critical action. In some cases, some of the writers of the scenarios will add that some critical errors that happens will end the scenario. So this depends and should be designed before implementation, and it's preferably not changed during. So for the clinical scenario or case, we expect, because the clinical scenario, basically, we want to mimic the reality of the clinicians. We expect it to be plausible. It can be found in clinical practice. The time frame is realistic, and the clinical progression and cues are plausible and can be applied and realistic for the organization itself, for the setting. And the critical action or the actions that will be assessed should be clearly stated. Of course, if there is a script, the scenario itself for standardized patient, it should be added too. If we are moving to the steps concerning the fidelity, so this is a key element in the scenario design. And this is basically what we do if we want to closely mimic or imitate the reality of the clinical practice. There are several types of fidelity, and the realism is what allows the participant to act as closely to how they would react in the clinical practice. And some of the fidelities, or the most commonly used, are the physical fidelity, conceptual fidelity, and psychological fidelity. The physical fidelity, it's concerned the physical environment of the simulation scenario. The conceptual fidelity is how this case itself transition or move or relates to a real case. And finally, the psychological fidelity is maximized when the simulation environments mimic contextual elements. So we add sometimes now noises or sounds that are similar, for example, to the AR rooms. This will make the simulation experience more realistic to the participants, and we will achieve more close reaction to the scenario than if we don't do this in this or clarify it in the design. So let's have a little activity. So going back to the scenario before, which is concerned MRSA and positive infection with multiple bit source. How would you ensure that the mentioned types of fidelities are implemented in this scenario? So the first one, how would you ensure that the physical fidelity are implemented in the scenario? You have option one, which is inform the participant of the simulation objective prior to the session. Option B, the theater room will have labeled droplets and contact precaution. Option C, monitor will show vital signs consistent with the diagnosis. You have closely 1 minute. Okay. You can share via the chat. You can add your answer. Okay, C, B, B.
We have C, B, B, 1C and 2B.
Okay. Anyone else?
Yellow, we want participant, please. We have 2C and 2B.
Okay. C, B. So most of the answers, I think C and B, B.
Yeah,
Okay.
C and B. Most of them C and B.
Okay. Okay. We have any more?
See, just to give me only 30 seconds.
Okay, great, great. Okay, we have 5 seconds. Okay, so the answer for this question is B. The theater room will have a label, droplet and contact precautions. Okay, the second question is how to ensure the conceptual fidelity are implemented in this scenario. The same options. You have 1 minute. Okay. Okay, see, I found an A.
Yeah, they are between C and A.
Yeah. Any more answers? Okay, we have more. Okay, we are done. Time up. Okay, so the answer is C, which is monitor will show vital signs consistent with the diagnosis. So a brief explanation about why this we chose those answers. So for the physical fidelity, which is the first answer, shows the droplet and contact precaution. We are dealing with the physical environment of the scenario. The scenario is patient suspected of MRSA. So we will set the room to be similar to a medical ward, which is a private room, and we will add the label, droplet and contact precaution, to be visible to the participants. So they will be aware that this room is, and the patient is infectious, and they will take the precautions. For the second question, which is the conceptual fidelity. So in this case, the writer of the scenario did not want to involve the patient parameters here too much. So she wanted it to be no change in the vital signs. Even if there is a change in the vital signs, the core elements here in the scenario, which is the vital signs. So either it's normal or the patient is angry or there is a complication. We are, in this scenario, we are using the vital signs, which is shown in the scenario. Moving on to the facilitator and facilitative approach. This is a very critical phase in the design. So if you are choosing an approach and how to facilitate the experience, you need to customize it to be implemented easily. And if you are planning to give a novice facilitator, they need to be officially trained on how to simulate on how to conduct simulation-based education activities. For the briefing part, this is a very important area. Briefing is, as we all know, it's everyone will brief the participants, but it's highly recommended that the briefing is structured and standardized, and it's also completed before the scenario case. You will brief participants of the expectation and the environment, the integrity and trust, the respect. We will orient them to the environment itself. One of the key aspects that we targeted in our center is to standardize the briefing process for the participants. So if in our center, we have a standardized approach to briefing. In our template, we added the section briefing and we added detail on how to, the time itself, how much time is suitable. And if the students have experienced a simulation before or not. This will be helpful for the educator team and the SSDC team to do the briefing and the orientation and more thoroughly. Rather than the 5 to 6 minutes, it will be more extended depending on the scenario. Of course, the brief description section will detail what is the case, what is expected of the participants. Another aspect is the fiction contract. The fiction contract is a confidentiality agreement. Details that the event basically is confidential and the participants are expected to not disclose anything related to the experience, and we will do the same from our part, the educator team. And we expect all participants in the simulation activity to sign. This is our approach to ensure a high quality briefing and preparation of the participants. For the briefing and feedback section of our element of the scenario design, most references recommend that even if we have several types or methods of debriefing, to add some recommendation regarding the suitable debriefing methods and when you are designing your simulation scenario. This will be helpful if the facilitator or the educator assigned for this scenario is a novice or have not much experience in conducting debriefing. It will be helpful for them to guide them through the debriefing process. Of course, experienced debriefer can conduct it and can use different methods, but it's highly recommended to add it. And all facilitators should go through training and debriefing techniques. There are many debriefing methods. You can use plus delta, advocacy inquiries, the PEARLS model, or team gains, or many other debriefing methods, depending on your aim or purpose of the simulation experience. The evaluation of the simulation experience is very important. It's divided into giving feedback and the debriefing, and there is also evaluation of the critical actions and the performance. Usually we do not share the checklists with the participants, and either if it's summative or formative, we only give the feedback. Also the evaluation of the conduction itself. So we get the participants' feedback of the experience, and the faculty and the educator or support team. This will be helpful to improve the quality of the simulation scenario or the curriculum. Of course, if you are preparing the participants, it will be helpful to provide learning materials for them. Also, this is also based on the outcome of the scenario. So if you are aiming, going back to my example regarding the infection control, you are expected to write down what are the materials they need to read or study before coming to the simulation scenario. Simulation scenario are mostly focusing on the psychomotor skills, not the knowledge, and the application. We also focus on the application of knowledge. So you can add reading assignments, the session, the lectures, and code of conduct, the confidentiality and expectation. Those all are recommended to be given to the participant prior to the simulation events. Finally, the pilot testing of the simulation scenario. This is what I call is the luxury step, which the educator usually, or the requester or the designer of scenario, will pilot the scenario among a group that is similar to their target participants. So we will have to ensure the validity and consistency and reliability of the scenario and the results. We usually use checklists to ensure that everything is going according to the session, and if there is any modification, should be edited. Of course, if it's not possible to be done, at least the minimum is to do a dry run of the simulation scenario with a smaller group to ensure that it's going smoothly and see it on the write-up. If it's good, it will be possible to implement it. We need to test it before the simulation event. So this concludes the part regarding the elements of the scenario. So how will you ensure that all those steps are implemented and done. What we did in our center, all of those elements were studied, and a quality assurance protocol was designed to ensure that all those steps can be implemented. There are a lot of steps, and we expect everyone in simulation to know, but it's a luxury to have an educator with a very experienced or high level of scenario design. That's why you need to apply a quality assurance protocol to ensure those steps are implemented. So usually the team is involved in the development, the review of the simulation scenarios, and the conduction and the evaluation. So this is a brief of the quality assurance protocol. We start with the orientation and training, the educator team, the simulation-based experience design, expert review, the simulation activity, and the evaluation. Those steps are very closely monitored together. So the first step is the orientation and training. For this step, why we did focus on two aspects, which is the training of the participant and the faculty. We train the participants because we want to ensure that all of them are trained on the simulation-based education activity and our policies and our procedures and our venues. They need to have all the knowledge related to those aspects. For the faculty, because each organization has their own procedure, policies, and their own aspects of scenario design, the faculty development program need to be customized according to the organizational needs. That's why our faculty development program focused on three aspects. One is the administration related issues and procedures, and what can the faculty use in our center. The second is the simulation-based education design. All aspects related to it, from the design to the scenario, to the design of curriculum, to the assessment, to the standardized patient modalities, to the modalities in general. And the final part is how to facilitate the simulation-based experience. Of course, there are onboarding programs for new educators, and if the participants could not attend the orientation or the training, which is conducted once a year at the beginning of the academic year for both faculty and students, there is an orientation prior to the simulation-based education, which takes to 10 minutes, where there's a brief script that is given by one of our educators to the participants. The next step, which is the educator team. So we drafted our policies and procedure to ensure that all simulation-based activities are closely monitored by at least one of our staff. This to ensure that all aspects of the simulation-based experience is implemented. That's the first one. The second is that is a safe learning environment. This needs to be ensured. And the final one is to facilitate the implementation. So if we have some novice facilitators or educators or faculty, our team will be there to help them facilitate the experience and make it more pleasant and more better for the participants and for the faculty, to encourage them to come and do it again for different aspects or different courses. For the simulation-based education design, so the first part was all of the elements. How we ensure that is we drafted different forms to ensure that those elements are applied. So we standardized, as I said before, we standardized the briefing, and we drafted a scenario template, and we added different forms for the needs assessment and for the assessment on the evaluation of the simulation-based experience. So if, for example, one of the requesters want to conduct a simulation, full simulation or a scenario in our center, we have a form they can fill, and we can assist them in the development of it. If you don't have a form the literature is filled with a lot of templates. This is an example of them, which is the template of events for applied and critical healthcare simulation. Moving on to the expert review. So our educator team are trained to review and develop the scenarios, but also we need a different point of view. What we did for this step is we developed a curriculum review committee that review all the scenarios and include different subject matter experts in both education and clinical practice. We have different specialties in this committee. That's why if we have different scenarios, we can give our feedback regarding different fields. For the evaluation step, we have to ensure in our center that all simulation activities are evaluated from the participants, from our faculty, and from our educators. This is a 360-degree evaluation. We use that and review it by our committees to ensure that the best standards are applied, and we review it also to find gaps to improve in our processes or in the simulation experience itself. After all that is done, the simulation-based activity will go through a process, conducting and improvement. And we ensure by that it's the best standard of practice that is applied in the simulation scenario experience. Thank you so much. If you have any questions, those are my references.
Thank you so much, Ms. Ghada.
In this my contact number. Thank you so much, Doctor.
Thank you for your informative lecture. It's very important. What you mentioned is very important. But I have one question about the pilot.
Yes.
Is it all the scenario we should make a pilot or no? Or maybe is it real that we implemented in the pilot every scenario that including the curriculum?
Yes, thank you for the question. Actually, this was up for debate and with some of our educators. So the pilot is, as I said, it's a luxury step. It is highly recommended that it's implemented, but it's sometimes the resources doesn't allow it, right?
Yes.
So for formative training, at least as I said, you do a dry run. Dry run, what happened there is we conduct a scenario sometime without participants, but we see it how it does transition from A to Z. So without participants, doesn't meet the requirements. We can't see anything, but at least we can see the flow and how it happens. So this is at least the minimum requirements for conducting the scenario. What piloting is critical for is simulation scenarios that are conducted for summative assessment. The piloting in this case is crucial and it can't be omitted and need to be done with the presence of a subject matter experts and the writer of the scenario and a pool of participants that is similar to the target audience. Because if we are planning to conduct, sadly, because we are dealing with human factor and not the, for example, questions, MCQ questions, for example, where we test the validity by running it, the results in a system. This is the only way we can test the validity and reliability of simulation scenarios, which is conducted real life with real participants and see how it goes. And that's my recommendation for the summative assessment of simulation scenarios.
Excellent. We have also a question from Dr. Sayed. He thanked you about your excellent talk and he asked, is there any published work template to make sure quality assurance of the scenario design?
Yes, thank you. Thank you, Dr. Sayed, for your question. Yes, currently, to my knowledge, there is only one published tool that assesses the quality of simulation scenario. Actually, this is an ongoing research project of mine to develop an assessment tool to ensure the scenario design. It's an ongoing project, but to my knowledge, there is only one tool that you can use in the literature. To be honest, the name is, I don't remember the name exactly, but I can share it later on. You can, I can contact you and send it to you, Doctor. Thank you.
Thank you so much. So, and there is also, he asked you to tell us about your project.
Yes, so the project is, what we did is conduct a literature review of all the available literature that discussed the quality assurance of simulation scenario. And we conducted focus groups with experts in simulation education based on the outcome of both those, the literature review and the focus group. We developed the instrument. And the instrument went through the piloting, and we are currently testing the validity of the instrument, and hopefully soon it will be published, inshallah.
Excellent. We have also one question from Prof. Boker. Do you use any validated forms like DASH for debriefing?
Yes, actually we use, for DASH, we have, for the evaluation itself, what we do to evaluate the activities is we customize the evaluation for different activities. We have for the full simulation or the simulation scenarios, for the procedural skills, for the OSCEs, and finally for the courses. For simulation scenarios, we use the DASH.
Excellent. Thank you so much, Ms. Ghada. Thank you all for all the speakers today. Thank you for all the attendance today. Our pleasure that you attend today for this second session for the simulation week. We hope you get benefit, and we will wait for a lot of benefit next and next. So Dr. Amani, she will enter, and she want to give some hint or talk.
يعطيكم العافية. شكرا دكتورة ريم، وشكرا عهود وغادة على their excellent presentation. And I just want to highlight for the conference, they will have a specific track for medical education. I've seen a couple of medical education experts موجودين في المحاضرات. I'm just highlighting in المؤتمر اللي في December, it's going to cover simulation and also medical education. So we welcome everybody to present and to be part of the simulation conference اللي حيكون إن شاء الله في December. ويعطيكم العافية جميعا. بعد ما تسكر الزوم إن شاء الله حيكون في الفيدباك. Please share with us your feedback regarding the presentation and the modality. Any feedback you want to send for us privately, you can send it through the email through the info or directly to me. ويعطيكم العافية جميعا، وشكرا على وجودكم. نشكركم على وقتكم اللي قضيتوه معنا. Thank you so much.
وإن شاء الله بانتظاركم للثيرد سيشن إن شاء الله غدا بإذن الله.
Yes. الثيرد سيشن بكرة راح يكون إن شاء الله الدكتورة سارة حتكون المودريتور. And التوبيك اللي راح يكون بكرة حيكون interesting for educator and for simulation expert. بحول الله حيكون التوبيك حق بكرة دكتور طارق حيتكلم عن the first 100 steps journey in running a simulation center, and دكتور رشكمار راح يتكلم insight to simulation from expert to St. Helena challenges and results. فنشوفكم بكرة على خير إن شاء الله.
شكرا للجميع، تصبحون على خير.
شكرا لك يا ريم، الله يعطيك العافية.
والعافية جميعا.